Hi everyone, I'm Luiz Fernando Falcão. I'm an anesthesiologist from Brazil. And for the next 10 minutes, we'll talk a little bit about enhanced recovery toward outpatient bariatric surgery. Before I start, these are my disclosures. So, every time when we're talking about enhanced recovery, we are thinking about improving quality and safety of our patients in order to decrease the complications after the surgery and as a consequence to have a fast recovery and decrease the length of stay. This can increase the efficiency of our hospital beds and bring economy and competitiveness to our hospital. When we talk outpatient bariatric surgery, maybe seems obvious for some countries or some centers, but this is not the reality for many countries on the globe. For instance, in Brazil, the average length of stay of bariatric surgery in public hospital are 6 days, and in a private hospital, 3 days. But we already know that when we implement enhanced recovery protocols in a bariatric surgery, we can decrease the length of stay in 1.5 days. We can decrease the complication rate in 30% without increased intervention and readmissions. So we can think that we can decrease the length of stay. Let's see what the literature shows us. In this very large study with more than 80,000 patients, they compare the patient which had discharge 2 days after the surgery or 1 day after the surgery. For the patients underwent to the bypass, which was more than 8,000 patients, their morbidity and the 30 days reintervention was higher for those patients discharged 2 days after the surgeries. For the patients underwent bypass, their morbidity and the 30 days reintervention and readmission was higher for the patients discharged 2 days after the surgeries. This means that discharge the patients on the postoperative day one, it's safe and is feasible. But we can move forward. We can discharge the patients before 24 hours after the surgery. In this paper, with more than 2,600 patients underwent to the sleeve gastrectomy, as we can see, 98.5% of the patients was discharged before 24 hours after the surgery. When we see the complication rate, the main complication was bleeding, dehydrating, and leakings, but it was lower than 1%. What is interesting is in this study pointed out that the main complications occurs before 24 hours after the surgery or occur after 5 days after the surgeries. This means that discharge the patients in 24 hours could be safe and feasible as well. So our question is, we can move forward and have a bariatric surgery as outpatients. In this study, with more than 3,000 outpatient sleeve gastrectomy, in this center, they use the EURAS protocol. They have 85% on the follow-up after the surgery. In the 30 days, they have the readmission and reoperation in only 0.6%, the reintervention in 0.2%, without mortality. The total complications after the surgery was 2.5%. And the main complication was gastric leaking and abscess, wound infection, and nausea and vomiting. So, if you want to treat those patients as outpatients, we need to understand the reasons that the patients can come back to the hospital, to the emergency department. In this very large study published in 2020 with almost 300,000 patients, The three main reasons that the patients coming back to the hospitals are dehydration, surgical site infections, and venous thromboembolias. We know that the dehydration has some risk factors to happen. For instance, patients younger than 40 years old, female, patients with more than 3 days of length of stay, patients underwent to gastric bypass, patients with gastroesophageal reflux disease, hypertension, DVP, with immunosuppression, or patients with postoperative complications are under high risk for dehydrations. And we need to take care when you treat those patients as an outpatients. But more than the patients coming back to the emergency departments, we need to understand the reasons and the incidence of readmissions after the surgery. In this study from Saudi Arabia with 300 patients, the readmissions happens in 8%. And the main reasons was abdominal pain with 37%, nausea and vomiting with almost 30%, and site leak. In this another study for Canada, the readmission rate in 30 days after the surgery was 7.5%. And the main reasons was infection, pain, and nausea and vomiting. In this another study from the American College of Surgeons National Surgical Quality Improvement Program with more than 30,000 patients, the readmission rate was 5%. And the main reasons, again, nausea, vomiting, dehydration, and pain. And in this study for France, with more than 180,000 patients, the readmission rate was 4.7%. With the main reasons was peritonitis, pain, nausea, vomiting, and bleeding. As you can see, we have many similar complications after the surgery, mainly nausea, vomiting, pain, and dehydration. But we have another complication as well, as peritonitis, as bleeding, leaking, and others. Therefore, if you want to treat those patients as an outpatients, we need to implement protocols in our centers. And these protocols need to follow an enhanced recovery recommendations. And enhanced recovery recommendations need to treat those patients in the perioperative period with many different points from a multidisciplinary approach. So as you can see, we need to address a multimodal opioid-sparing analgesia to avoid pain after the surgery. We need to do a multimodal prophylaxis for nausea and vomiting, as well as we can start with early oral fluid intake. In a couple of months, we'll publish the new guidelines, the new era's recommendations for bariatric surgery. And here are the main recommendations for this new guideline. As the last guideline from 2016, we have many different recommendations from the preoperative period, as you can see. And in this preoperative period, we still have a low recommendations with a low level of evidence to use dexamethasone in the preoperative period to avoid nausea and vomiting. But in the intraoperative period, we still recommend with a strong recommendation with a high level of evidence, a multimodal approach for the postoperative nausea and vomiting prophylaxis, as well as the recommendation for in the intraoperative period to do a multimodal opioid sparing analgesia. And in a post-operative period, we have many recommendations. And as you can see here, we recommend a clear liquid regimen can usually be initiated in a couple of hours after the surgery. This is a strong recommendation, and we don't need to wait a long time after the surgery to see if this patient has a tolerance or not to drink liquid. As a conclusion, to move forward, and to move towards an outpatient bariatric surgery, we need to implement an enhanced recovery protocols. And for this, we need to improve at least 1% in each step of the surgical journey of our patients. We already know that what we need to do, but now our main challenge is how to integrate what we already know into practice. Thank you very much.